We have 6 distinct clinical stations to rapidly hit today. We're starting with the heavy lifting of gastric cancer, moving right through stromal tumors and mechanical emergencies, and we'll wrap up on a highly memorable psychiatric case that you absolutely won't want to miss. Let's get to it.
Section 1. Gastric Cancer Essentials, Risk Factors and Classifications. So, you probably already know that globally, the antrum, that lower part of the stomach, remains the absolute most common site for gastric cancer to develop. But what's really fascinating is that in the Western world, the incidence of proximal gastric cancers, the ones higher up, is steadily rising. And looking back at historical data, it's honestly kind of wild to see how the invention of mass refrigeration literally caused gastric cancer rates to plateau and even drop in some areas. Why? Simply because it reduced our reliance on preservative-rich, smoked foods. Of course, we also see strong genetic and infectious links here. We're talking H. pylori bacteria, true adamantomatous polyps driven by the APC gene mutation in FAP syndrome, and even a really interesting correlation with the type A blood group.
Now, Lauren's classification is our primary pathological way of dividing these gastric cancers, and the contrast between the two main types is stark. The intestinal type is largely driven by those environmental factors we just mentioned, like gastric atrophy, and it tends to show up more in older men. But then you have the diffuse type. This one is a genetically driven rogue. It's highly associated with the CDH1 gene mutation, which causes decreased E-coherin, and it actually presents more often in younger women. Pathologically, the diffuse type is famous, or maybe infamous, for those poorly differentiated signet ring cells. They are incredibly aggressive, just spreading right through the stomach wall and lymphatics.
The absolutely crucial point for any clinician is distinguishing early cancers, which sit just above the muscle layer, from the advanced ones that invade much deeper. For those advanced cancers, we rely on Borman's classification, and you must recognize Borman's type 4. This is the dreaded linitis plastica, or leather bottle stomach. The cancer diffusely infiltrates the entire wall of the stomach, turning it severely rigid. Across the board, this presentation carries the absolute worst prognosis. On the flip side, if we're talking molecularly, tumors with microsatellite instability, or MSI, generally tend to have the best prognosis.
Section 2. Atypical signs and surgery, clinical presentations and resection.
While advanced cancer has actually overtaken peptic ulcers as the most common overall cause of gastric outlet obstruction, its atypical metastatic signs are even more vital to catch. These are your red flags that the cancer has already spread far beyond the stomach. Take Sister Mary Joseph's nodule, for instance. That's a metastasis right at the belly button. Fun piece of medical history, it was actually named after the incredibly perceptive head nurse of Surgeon William Mayo because she was the very first person to consistently notice these periumbilical nodules in their patients. We also have to watch out for Krukenberg's tumors. Those are bilateral ovarian masses packed with signet ring cells spreading via retrograde lymphatics. Oh, and never ever forget to palpate for Virchow's node in the left collarbone area. It's a classic textbook sign of advanced gastrointestinal spread through the thoracic duct.
So let's talk surgery and how we actually clear those lymph nodes. The Japanese surgeons dealing with historically high local incidence rates map this out perfectly for us. A D1 clearance just takes the lymph nodes stations numbered 1 through 6, which are right there hugging the stomach. But if you truly want to give the patient the best possible surgical outcome, you have to move to a D2 clearance. This goes deeper. You're removing stations 7 through 11, tracking right along the major blood vessels like the left gastric and splenic arteries. D2 is without a doubt the gold standard clearance.
I want you to remember this number, 15. Because lymph node stations can contain multiple individual nodes, you can't just count the stations and call it a day. It doesn't matter what the scope of the primary gastric resection is, whether you're taking a third of the stomach or removing the whole organ entirely, a minimum of 15 individual lymph nodes must be physically removed and examined by the pathologist. If you don't hit 15, you haven't successfully achieved that optimal D2 clearance.
Section 3. GIST explained. Gastrointestinal stromal tumors.
Now, unlike adenocarcinomas, gastrointestinal stromal tumors, or GISTs, play by a totally different set of rules. They don't arise from the inner stomach lining at all. They actually originate from the interstitial pacemaker cells of Cajal. Those are the cells controlling your digestive tract's motility, and the stomach happens to be the most common place they pop up. Because lymphatic spread is surprisingly rare with GISTs, we're talking less than 10% of cases, these tumors behave a whole lot more like sarcomas. They invade locally or they spread through the blood. To diagnose them, we rely heavily on specific immunohistochemistry markers. DOG1 is your most specific marker, along with CD117. Also, keep an eye out for the SDHB gene mutation. If a patient has that, their tumor is going to show primary resistance to imatinib, which is the standard targeted therapy drug. So, oncologists have to pivot fast to alternative meds.
Because of all that, surgically, these two types of tumors are handled completely differently. You know how with the standard gastric adenocarcinoma you need massive 5-centimeter margins, complete removal down to the pylorus, and that grueling 15-node minimum clearance? Well, GISTs are a totally different ballgame. Since they rarely touch the lymphatic system, a GIST only needs a really conservative 2-centimeter surgical margin. A simple wedge resection of the stomach wall is usually totally sufficient, and you can skip the routine lymph node clearance entirely.
Section 4. Gastric lymphoma and maltoma, lymphatic involvements.
The stomach might seem like a really strange place to find a lymphatic cancer, but it's actually the most common extranodal site for all gastrointestinal lymphomas. And within this category, we find maltomas, mucosa-associated lymphoid tissue tumors. Now here is one of my absolute favorite medical phenomena. It's a classic trivia fact among physicians. How do you treat a low-risk maltoma? Because this specific tumor's development is so heavily triggered by an underlying H. pylori bacterial infection, you don't actually send the patient to surgery. You don't even start with aggressive chemo. You can effectively treat and resolve this low-grade tumor simply by prescribing a round of antibiotics to eradicate the H. pylori bug. How amazing is that?
Section 5. Gastric volvulus, mechanical twisting of the stomach.
Stepping away from tumors entirely for a minute, let's talk mechanics. Gastric volvulus is a severe, life-threatening mechanical twisting of the stomach itself. There are two primary types you need to know. Organoaxial is by far the most common and the most dangerous. In this scenario, the stomach twists along its long axis, right from the top cardia to the bottom pylorus. The reason this is so incredibly dangerous is because it causes complete vascular compromise. It literally chokes off the stomach's blood supply. We frequently see this associated with diaphragmatic defects, like rolling hiatal hernias, where the stomach manages to slip up into the chest cavity and then twist on itself. If you ever have a patient present with Borchards triad, you have an absolute life-or-death surgical emergency right in front of you. The triad is this: severe upper abdominal pain, violent retching but with no actual vomit coming up, and crucially, the physical inability for a doctor to insert a nasogastric tube. You literally cannot push a tube past that twist. If you see this, you need to rapidly confirm it with a CT scan and immediately prep for a surgical gastropexy. You have to get in there, untwist it, and permanently anchor that stomach before the tissue dies.
Now, as we approach the end of our rapid-fire rounds, I want to pose a question that transitions us into the truly bizarre side of gastric surgery. What exactly happens when a severe psychological compulsion manifests as a physical surgical emergency?
Section 6. Bezoar's and Rapunzel syndrome. Atypical gastric obstructions.
So, bezoars are these rock-solid masses of indigestible material. They accumulate over time in the digestive tract, and eventually they lead to a total gastric obstruction. The most famous of these is the trichobezoar, which is quite literally a massive hairball. This happens in patients suffering from a specific psychiatric compulsion to eat their own hair. Now, when this hairball grows so incredibly large that it takes the exact anatomical shape of the stomach and its tail extends all the way down into the duodenum in the intestines, that extreme presentation earns the clinical name Rapunzel syndrome. And it's crucial to understand that beyond just the massive surgical undertaking to remove this thick cast of hair, these patients absolutely must receive ongoing psychiatric care to prevent the compulsion from returning.
And I'm going to leave you with one final staggering number today: 600. That represents the number of distinct metallic objects, and yes, that included intact glass Diwali lights, found inside the stomach of a young psychiatric patient who was dubbed Metal Omen by his surgical team. His life was miraculously saved from dozens of deadly perforations for one crazy reason: he had also swallowed 2 powerful magnets. Those magnets clamped all 600 dangerous items together into one giant, relatively stable metallic bezoar. It's a pretty wild end to our fast-paced medical rounds, wouldn't you agree? But it really makes you think, if the human stomach can survive a twisted axis, aggressive cancers, and 600 pieces of jagged metal, what other terrifying medical mysteries is the human body hiding in plain sight? Thanks for joining me on this explainer, and keep that clinical curiosity fired up.